Solving Problems Through Interventions, the Pennsylvania State University College of Nursing, Nursing 848. Hello, my name is Megan Manning, and I am a graduate student at the Pennsylvania State University. The purpose of my project is to present an intervention regarding high dust in operating and procedural rooms. This presentation will last approximately 15 minutes in length. I hope you enjoy the content of this presentation, and I look forward to your questions, comments, and/or feedback. The Joint Commission has identified high dust in operating and procedural areas to be a health safety hazard, putting patients at risk for hospital-acquired infections when entering and exiting these areas. High dust occurs when there is minimal outline for cleaning personnel performing cleaning procedures. For example, before case cleaning, between case cleaning, and terminal cleaning. The purpose of this project was to assess high dust in operating and procedural areas by performing a risk assessment to identify how big the problem really is within this organization and execute an improvement plan via enhanced education and re-education methods. There is a higher risk for infections in operating and procedural areas. Some reasons may include, but are not limited to, the normal skin barrier is typically compromised. For example, a patient with a surgical incision site. Common equipment is utilized on every patient. Team members, such as nurses, physicians, and technicians, are continuously accessing high-touch areas. High dust accumulation can be found within a sterile area. A reservoir is an area where dust or germs live on surfaces. When there is high dust on reservoirs in operating and procedural rooms, it poses a risk for infection. Cleaning and disinfection should take place on all reservoirs in operating and procedural rooms. The image pictured here was developed by the Association of Perioperative Registered Nurses, or AORN, Recommended Practices for Environmental Cleaning. This image displays many of the high-touch areas and objects in operating and procedural rooms. Dust, debris, and contaminated cleaning solutions could contaminate the items pictured if cleaning is not properly performed from top to bottom. The colored handprints in this picture represents cleaning frequencies in operating and procedural rooms. For example, after every patient, only if used, enhanced, and if soiled. As one can see, the amount of surface space covered within the operating and procedural rooms is vast and can range from high to low. Cleaning in these areas is of high importance to ensure infection is not spread from one patient to the next. A risk assessment was completed to determine how big the problem of high dust really is. The risk assessment process utilized for the purpose of this project is shown here. The risk assessment includes identifying the risks of the problem, creating goals, developing and implementing a plan, evaluating the plan. It is important to continuously assess, reassess, and repeat each step as needed to ensure the best outcome. Shown here and on the following two slides is a detailed risk assessment of high dust in operating and procedural areas. Areas of the risk assessment include description of hazards and/or risks, risk level, control measures, remaining risks, and the planned and/or monitoring techniques to be utilized. After utilizing the risk assessment noted on the previous slide, the risk level for high dust was found to be high. In the interest of time, I will not detail each area of this risk assessment, rather highlight some important factors throughout the remainder of this presentation. Please note, this risk assessment remains in draft form at this time. Again, this is a continuum of the risk assessment. This is the final portion of the risk assessment. Policy revision, competency development, and formalized education and training were finalized using the AORN recommended practices for environmental cleaning. Policy revisions were approved by the legal department prior to dissemination and reflect both nursing and environmental services. The competency development was finalized and is specific to registered nurses, OR technicians, and environmental service employees and is shown on the next slide. An educational PowerPoint was placed in unit-specific binders and distributed to all OR and procedural areas at the 3 Northeast campuses within this organization. Formalized education is underway and will be completed by the OR and procedural area nurse educator and environmental service leadership team. Staff are required to take a pre- and post-test to assess knowledge prior to and following competency sign-off. The competency shown here was built utilizing the newly implemented policy following the AORN recommended practices for environmental cleaning. The name of the organization has been removed for privacy and confidentiality purposes. The standards listed are specific skills and knowledge required to perform the job of cleaning in OR and procedural areas based on established criteria. These standards were pulled directly from the organizational policy. Level of proficiency is assessed to determine if a reassessment may be needed prior to final sign-off. Learning methods may include a review of policy and practice with supervision. Assessment methods include demonstration, post-test, interview, and observation. An employee may be deemed competent once all standards are met and can be performed independently. The resources that currently exist within the OR and procedural areas include environmental service personnel, registered nurses, and OR technicians, a policy for environmental cleaning, and environmental service duty lists. Duty lists serve as a guide for environmental personnel when cleaning assigned areas. In reviewing these documents, we noted that there are inconsistent practices between areas and shifts. Additionally, observations and interviews found to have areas not being performed by assigned personnel as indicated on the duty lists. No additional resources were added as a result of this project intervention, rather a reallocation of staffing resources for appropriate timing of cleaning. The duty lists shown here are an example of what is utilized by environmental services in the OR on both day shift and night shift. The name of the company has been removed for privacy and confidentiality purposes. Please note there are variations noted to each list, despite being the same area. For example, the OR rooms do not match on both lists. one having a histology OR but no OR7, whereas the other list has an OR7 but no histology OR. Additionally, the 7-step cleaning process utilized by the company is not consistent between each duty list. Variations in duty lists can cause problems such as lack of high dust cleaning between employees. Though these forms are a working document for environmental staff, our group felt that they should be as accurate as possible to allow for a consistent workflow for staff utilizing this form. We also felt that these forms could serve as documentation should it be needed to be presented in any survey of any type. Barriers and challenges we have faced or expect to face in the near future include staffing patterns, variation in cleaning procedures and compliance with revised and updated policies, and education scheduling. There is currently an employee who works night shift and has for many years who will be transitioning to day shift. This change will disrupt the normal flow of the terminal cleaning process. Training for oncoming personnel of roles and responsibilities will need to take place and can be time-consuming. It will likely take these individuals some time to establish a routine. Currently, there is variation in cleaning procedures and cleaning materials. Turnover in the OR and procedural areas is rapid. Cleaning in these areas will need to wait until after a patient has left the room. This differs from the current practice of beginning cleaning prior to the patient exiting the room. This can cause a delay in room turnover and next case start time. Once re-education is finished, staff will need to adapt and comply with the evidence-based practice guidelines in place. Incorporating these updated practices into their workflow is a change, and with change comes a challenge to adhere. Education in these areas can be challenging due to the nature of the flow of these areas, with personnel being in cases, performing room turnover, etc. Education scheduling will need to be flexible to allow for all staff to be trained using the revised policy. Outcomes of this intervention include a finalized policy, regulatory rounding, employee file audits, and duty list audits. The revised policy was presented to Infection Prevention Committee, Environment of Care Committee, Med Exec Committee, and Administrative Policy and Procedure Committee prior to finalizing. Based on feedback, revisions to the policy were made, and the policy was finalized through the legal department. Scheduled and unscheduled rounding will take place to assess compliance moving forward. Quarterly file audits will be completed to assess competency state and sign-off compliance for all employees performing OR and procedural area cleaning. Audits of duty list form completion will occur monthly for 3 months, and then quarterly audits will take place. This project intervention presented a unique opportunity to partner with many different disciplines throughout the organization. This partnership included the Environmental Services Leadership Team, Quality Improvement Managers, the Director of Regulatory, the Director of Infection Prevention, OR and Procedural Leadership Teams, and the Senior Director of Risk Management. Through this, our group was able to revise the current policy, revise the environmental services duty lists, develop a consistent competency, and develop education and training for all staff involved in OR and procedural area cleaning procedures. The theoretical framework utilized in the development and implementation of this intervention is Kurt Loewen's change theory. Kurt Loewen identified 3 phases through which the change agent must proceed before a planned change becomes part of the system: unfreezing, movement, and refreezing. The change theory framework was utilized in this process due to the quality improvement efforts of the organization that would impact employee work and patient outcomes. Recognizing, addressing, and overcoming resistance is important to ensure continued success of the implemented processes. Continued involvement of staff in this change is important to encompass communication, collaboration, and buy-in. In conclusion, high dust in OR and procedural areas poses a risk for infection. Dust is located on high reservoirs and high-touch areas and should be cleaned from top to bottom. A risk assessment was completed to determine how big high dust is. Inconsistencies in competencies, policies, and education and training are causes of high dust accumulation. Revision of duty list and policy was completed and disseminated to all staff. Competency development was completed and utilized for education and training purposes. Change theory framework was utilized to ensure successful implementation. The role of the nurse leader is to recognize, address, and overcome resistance and serve as a role model in a time of change. Partnering with available resources will ensure a smooth and successful transition. A risk assessment was necessary to show that there is, in fact, a problem and identify how big that problem really was at the start of this project. Throughout this process, we have identified many more layers than just high dust in OR and procedural areas. Identification of these additional areas of focus can only help to improve quality and outcome of our patients entering and exiting these areas. Partnership and collaboration is the key to success. This involves communication amongst all involved personnel. Communication is needed to ensure understanding and follow-through at time of implementation. Utilizing evidence-based practice leads to better outcomes and success within the organization. This is a win-win situation. References listed on this slide are those that helped shape the framework for the identification and implementation of this organizational problem. I hope you have enjoyed the content of this presentation and are able to utilize this work in your future practices. All of my best.